Welcome back. So we have already seen part 1, and here in part 2 we'll be moving further. We had ended with the life cycle of H. nana and the treatment as well. So now we'll be moving forward, and this is nothing but the that's parasitology part 2. So here we'll be moving ahead, and we will be seeing what is known as the liver fluke. So do you know the other name? It is nothing but the fasciola hepatica. So we'll be moving to that. It's also known as hepatica. So looking at points of this, it is known as the sheep liver fluke, or also known as the common liver fluke. These are the important terms that we need to know, and it was the first trematode to be described. Interesting fact, it is the first trematode to be described. And now moving ahead, it is mainly present as a sheep liver fluke. The name suggests it is present in sheep growing countries, and they can live in liver of sheep, cattle, goat, and man. So now we'll be looking at some morphology. Firstly, a diagram needs to be known of fasciola hepatica. This is how it looks. Here there is ventricle sucker that's present. There is presence of ovary as well. Testicles are present, testis, and also there's intestinal CK, as well as conical projections. Let me quickly label them. Oral sucker. This is the ventral sucker. This is the intestinal CK. This is uterus, ovary, the testis. So these are the important aspects that need to be known. Oral sucker, ventral. So here it goes: oral sucker, ventral sucker, then intestinal CK, uterus, ovary, and testis. So these are the parts of the fasciola hepatica. Now moving ahead, looking at the points. In case of the adult worms, we are focusing on the morphology. So the adult worm is nothing but it's a leaf, large leaf shape. Okay, and then it is about 30 mm into 15 mm, and it is bilaterally symmetrical, and has conical projections important conical projections at the anterior. The anterior portion, and the ventral sucker is present nearby in line with two shoulders. The intestinal CK as well as the testis are extensively branched. Other important point to note is the lifespan is up to 10 years. Now going to the eggs of the fasciola hepatica, this is how it looks. So here you have the operculum, that's the space, and here we are filled with cells. Okay. Now the points to add on here are, it is egg. So this is about the egg. The egg is large and it is operculated. It is bile stained and measures up to 140 micrometer into 80 micrometer, and what it contains is, it has immature larva, and the miracidium. The eggshell is thin with smooth surface. So the eggshell is smooth surface. And another point to note is that the egg cannot be differentiated. So the egg is almost similar to that of the Fasciculopsis busci or busci. So here some important aspects to know is the life cycle. Life cycle is nothing but the adult worm live in the biliary passage of liver in definitive host. Then what happens is, the egg is passed in the feces and move on to the fresh water, and the embryo is present. It matures. Then what happens is, the free swimming miracidium is present. So what this does is, it penetrates the tissue of intermediate host, that is snail. Then it moves on to the sporocyst, and we have the first generation radia. It progresses to the second generation. Then we have the Calcarea. These are all nothing but the maturation stages, and it ends on aquatic vegetation. This needs to be known. Then there's formation of Metacaria, Cercaria, what this does is, this moves on and the definitive host, it acquires the infection. This is mainly due to uncooked plants. Mainly due to uncooked plant. This, it moves on. Then the metacercariae exist is present in duodenum. It moves on to the peritoneal cavity. Then moves on to liver. And then to the biliary passage. Then matures into adult worm. This is a bit long, so I'll be revising it again. So what happens is, the adult worm, it is present in the biliary passage of the liver in the definitive host, and then the egg is passed out in the feces and is moved on to the fresh water. The eggs are moved on to the fresh water, and then there are free swimming and free swimming miracidium. It penetrates through the tissues of the intermediate host, that is the snail, and then it forms the sporocyst, which forms the first generation redia, and it forms the second generation redia, and then it moves on to the cercaria and encyst the aquatic vegetation and matures into the metacercaria. Then what happens is, the definitive host acquires the infection, and then the metacercaria encyst in duodenum and moves on to the peritoneal cavity and goes to the liver, biliary passage and adult worm. So this was the life cycle. Other points to note in the fascicula hepatica is the lab diagnosis. So looking at the lab diagnosis, under this, firstly we'll look at the stool examination. Next, we'll be looking for high eosinophilia. Next, we'll be looking at the serological test, and this includes ELISA and it also becomes positive mainly with 2 weeks of infection, and it can turn negative as well. So it is negative after the treatment. This needs to be known. And now focusing on the treatment, oral Bithionol is used. Oral bithionol, it is used, is the treatment of choice, as well as triclabendazole along with dihydroemetine are used. Next, moving on to the prophylaxis. Under the prophylaxis, firstly, as mentioned earlier, we basically educate, health education. Then the animals, they need to be treated, the vectors, so that there's no spread, and avoid eating raw food because it can be a source, as well as destruction of the molluscan host destruction. These needs to be followed. Now just repeating the points. So lab diagnosis, we have the examination of the stool, and there's increase in eosinophilia, and serological tests such as ELISA and are done. And looking at the treatment in case of a negative result, that means the treatment has begun. And now moving on to the treatment, the oral butanol is used, and other alternative drugs being labendazole as well as dihydroemetin. Now looking at the prophylaxis, it's general, that's health education, animals should be taken care of, then avoid raw food, and then molluscan hosts are destroyed. Now just moving on to the next topic, we are done with Fascicula hepatica. We'll be moving on to the other famous worm, that is this is known as Ancylostoma duodenale. So this is the worm we'll discuss. It is commonly known as the roundworm. Let me write it down. This is our aka roundworm. It's not the roundworm, it's known as the hookworm. So here we'll be looking at the structure of the egg, morphology. So this is how the Ancylostoma duodenale looks. And this is nothing but the shell membrane. These are the blastomeres, and this is the segmented ovum. So these are the things: the shell membrane, blastomeres, and segmented ovum. Now looking at the morphology of the adult worm, here it is small, greyish white and cylindrical in shape. Cylindrical, grey white. The other point is that, and the anterior end is bent. So that is why it's known as hookworm. And next point is the body shows curvature. The oral aperture is, we see that the oral aperture is directed towards the dorsal surface, is present on the dorsal surface, and the buccal capsule has 6 teeth and 4 hooks, as well as 2 knob-like structures. These are some additional information which we need to know. And another interesting point is that the male worm, the female, is larger than that of the male in terms of length. and the male and female are distinguished mainly based on the length, since it's easily visible. Next we are looking at the copulatory bursa. So it is the structure in males that is present for the attachment of the female during copulation, and it has 3 lobes. So in this, one is dorsal and next 2 are ventral or the lateral lobes. Now each lobe is supported by a chitinous rays. So we can see that each lobe has chitinous rays, and the total chitinous rays, the dorsal lobe contains 3. See, the dorsal, it contains 3, and the lateral lobe contains 10, and the dorsal ray is partially divided at the tip, and each division is, see, it's divided in the tip, and each division is a tripartite. Now we're looking at the lifespan. The lifespan is about 3 to 4 years. This is the lifespan. So now we have already drawn the structure of the egg. Now just to summarize, the egg is oval, and it is colorless, and important point, it is non-bile stained, and it has a thin, transparent, hyaline shell membrane, and it has a segmented ovum with 4. So it's nothing but a segmented ovum, and this contains 4 blastomeres. Now moving on, the clear space is also present. There's presence of clear space, and the egg floats in saturated salt solution. This is an important point to note. Floats on saturated salt solution, and a single female worm lays about 25,000 to 30,000 eggs. Single female, so it lays about 30,000 eggs, and the eggs are normally excreted in the feces, and if you look at the time, in the feces, it's excreted in the feces in about 4 to 7 weeks of infection. Now quickly looking at the life cycle, we have the adult worm in small intestine. What this does is there's eggs in feces, and there is the rhabdiform larva, and this larva is attached to soil. Next, what happens is the filarial form larva develops. And what this does is penetrate skin. Next, it enters the circulation. Then it affects the lungs, trachea, as well as the larynx. Next, what happens is it moves on, affects the pharynx as well. It moves and it's swallowed. Next, the larva, it settles in the small intestine. Then goes on in the small intestine. So now I'll just repeat. So the adult worm is present in the small intestine, the eggs get transferred in the feces, and then the rhabdiform larva, it is hatches out, and then it is present in the soil. It develops in the filarial form, penetrates the skin, enters the circulation, goes to the lungs, trachea and larynx, and also the pharynx, and then swallowed, and then it finally settles in the small intestine. So this was the life cycle. Now quickly looking at the lab diagnosis. So this is the lab diagnosis. Under the lab diagnosis, what we are seeing is there are direct methods. Under direct methods, it's nothing but stool examination. The second point being there can be duodenal contents can also be checked. So under stool examination, going into a bit of detail, it is to check the adult form of the worm. So this is done by some concentration technique is used. And one problem is that the eggs of Acyclostoma duodenale as well as that of N. americans, it cannot be differentiated. So it's very similar. This is one point to be noted. And the specific diagnosis can be made by studying the morphology of the worms. So there should be a detailed on the morphology should be learned, is to be known. And the stool specimen is stored in room temperature. Stool to be stored in room temperature, and this should be for more than 24 hours, and the larva must be differentiated from this thing. It should be differentiated from strongyloids larva. Differentiated from. And as mentioned earlier, it lays about 25,000 to 30,000 eggs. and this indicates the severity of the infection. The number indicates the severity of the infection. Now, looking at some of the indirect methods. In case of indirect methods, under this there is the blood examination. Under blood examination, it reveals microcytic and hypochromic anemia, as well as eosinophilia. Now, looking at the other examination, in the stool examination, what we are seeing is it reveals occult blood and Charcot laden crystals in majority of cases. So now quickly I'll summarize. In case of the lab diagnosis, there is direct, that is stool examination and the duodenal content. In case of stool examination, we are looking for the adult worms, and the concentration techniques are used. And one challenging task is Ancylostoma duodenale and N. americanus is very similar. And looking at what we are seeing under the microscope is by the morphology, we are able to differentiate them. Then the stool is stored at the room temperature for more than 24 hours, and it should be differentiated from that of Strongyloids larva. There are about adult female hookworm lays about 25,000 to 30,000 eggs, and the number, it indicates the severity of the infection. The indirect methods include the blood examination. We are able to see a microcytic hypochromic anemia as well as eosinophilia. And the stool examination contains occult blood and the Charcot laden crystals. This is a very important MCQ. Charcot laden crystals are present in cases of that of Ancylostoma duodenale. So we have come to the end of Ancylostoma duodenale. Now we'll be moving on to the next topic, that is we'll be focusing on the topic Trichuris trichura. So I'll write it here. It is called as Trichuris trichura. So here it is a common name for whipworm. It's also known as whipworm, and the worm, it is common in tropics. We need to know a few points. That is, it is in tropics, and it is present in the large intestine and particularly in cecum, and also appendix and colon. So this is the important points. Now moving on to the morphology. So this is how the egg looks. There is mucus plug. Next, there is on both the ends there is the mucus plug. That is the main feature. Now quickly looking at the life cycle, as we always do. So here we have the adult worms in large intestine. Next, what happens is it goes as egg in feces, It's common in most of the worms. Next, it goes and develop in soil. And then the embryonated egg, it contains rhabdiform larva. Next, what happens is the man gets infected. So man is infected from this, and the source being contaminated food or water. Next, it moves on the cycle, and it leads to the eggshell is dissolved by the gastric juice. Shell is dissolved by gastric juice. Next, it moves on and the larva emerges, and this is through the pole of the egg. Next, what happens is this moves further and the larva is liberated. The larva is passed on to the cecum. So it is passed on to the cecum as well as the parts of large intestine. There it develops into adult worm. So then the cycle continues. So just to summarize, it is also known as whipworm. It's present in tropics, and large intestine, cecum, appendix and colon are the common sites. So here going by the structure of just the diagram so that we can associate. This is the mucus plug that is present on the poles. Now looking at the life cycle, the adult worms are present in the large intestine. There is eggs present in the feces, and what happens is there's development in the soil because of the feces. Then the embryonated eggs contains the rhabdiform larva. The man is infected. This is due to the contamination of the food and water. Then the eggshell is dissolved by the gastric juice, and the larva emerges through the poles of these eggs. And then the larva is liberated and then moves on to the cecum and the large intestine, where there's development into the adult worm. So now we are done with the cycle. Now we quickly look at the morphology. So in case of the adult worm, let me draw the adult worm. So we are looking at Trichuris trichura. Trichuris trichura. So this is how it looks. It's a bit curved. So this is nothing but the female, and this is the male. We can see the difference. And this is a very thin, nothing but a very thin anterior portion. So it's very thin anterior portion that is present, and then the coiled posterior end is present. Coiled posterior end is noticed, and then this is nothing but the coma or arc shaped posterior end. Coma or arc shaped posterior end. Now we'll be quickly looking at some points. The adult worm is whip shaped. You're able to understand that. and the male worm, it measures up to 30 to 40 millimeter, whereas the female, this is the male, whereas the female, it measures up to 40 to 50 in length. Now looking at the anterior 3/4 of the worm, nothing but the anterior 3/5 of the worm is very thin. It is thin and hair-like. Okay, as compared to the posterior. So what we are seeing is the posterior toothed is the posterior 2/5 is thick and stout. So it's thick. Posterior 2/5 is thick and it resembles the handle of whip. Interesting point. Now the males have posterior coiled posterior ends, as the image depicts. The male has posterior coiled end, and the posterior end of female is coma shaped. It's here. It is coma shaped or posterior end, and the thing to note is the lifespan is about 5 to 10 years. And looking at the egg as drawn earlier, so it has the mucus plug that is present. So looking at the eggs, they are barrel shaped. Eggs are barrel shaped. They project mucus plug at each pole. Mucus plug is present at each pole. Then what happens is the plugs are colorless and they measure about 50 into 25 micrometer in size and are freshly passed, and the freshly passed eggs contain unsegmented ova. So the freshly passed contains unsegmented ova and are not infected to man. Infected to man. So now quickly revising, we spoke about Trichuris trichura. It has a lifespan of 5 to 10 years, and we have the female and the male. So the male is smaller, that's 30 to 40 nanometer. Female is 40 to 50, it's a millimeter. And then what we see is the female, it is coma or arch shaped in the posterior end, whereas the male is coiled posterior end, and it has a very thin anterior portion. And this posterior 2/5 is thick, and it is nothing but it resembles that of the handle of the whip. And the anterior 3/5 is thin and it is hair-like. Next we have the mucus plug. It is barrel shaped and the mucus plug is present at both poles, and the plugs are mainly colorless, and it has about 50 to 25 micrometer in size. And then we also have the freshly passed. It has the unsegmented ova as well as it's non-infected to man. They float in saturated salt solution. I would like to add this point. They float on saturated salt solution. Okay, let's revise that. Float on saturated salt solution. Now we'll move ahead with the lab diagnosis. It mainly depends on the stool examination. So looking at lab diagnosis, it is nothing but stool examination. And looking for the characteristics as mentioned earlier. And also it is adult worms. We need to know that it is not found mainly in stools. Majority are not found in stools, and they are stuck in, they are buried in the large intestine. This is an important point. This needs to be known. Next, looking at the treatment, it is nothing but mebendazole is administered. It is given 100 milligram twice daily, and this is given for 3 days. Then prophylaxis would be similar, that is fecal disposal should be noticed, and avoid consumption of raw vegetables. As well as the treatment of patients should be done effectively. Now, looking quick note on the infections caused, that is the pathogenesis. It results in a condition known as trichuriasis, also known as whipworm infection, and it is mainly asymptomatic. And it may result due to mechanical effects, or there can be allergic reactions as well, which can lead to symptoms. And other point to note is there can be dysentery, and this is known as the whipworm dysentery, and abdominal cramps are also seen. And this results in massive infection. So just quickly summarizing, we saw the lab diagnosis. It is by stool examination, and adult worms are not present in stool. It is buried mainly in the large intestine, and the treatment is mebendazole. It's given 100 milligram twice daily for 3 days. And prophylaxis is by safe disposal of feces and avoid consumption of raw vegetables, and the effective treatment of patients to be done. And pathogenesis includes it causes diseases such as trichuriasis or whipworm infection. It is mainly asymptomatic, but it can lead to some allergic reactions as well. And the whipworm dysentery it leads to massive infection and can also lead to abdominal cramps as visible signs and symptom. Next, moving on, we will be looking at trichuria. We are just done. Next, we are looking at the microfilaria. So, concept of microfilaria. So what are microfilaria? So it's mainly found in Wucheria bancrofti, the embryonal form is known as the embryo form is nothing but microfilaria. So adding on to some points of microfilaria with respect to the Wucheria bancrofti, they are colorless and transparent. It has blunt heads as well as pointed tail. The embryo measures, so the measurement is 250 into 7 micrometer. Interesting point, hyaline sheath is covering it, covers, and the sheath, what we see, is longer than the embryo, and the movement is seen. The movement of the filaria is seen. Movement is seen due to the bigger structure. What is other point is that the somatic cells or the granules are present in central axis of embryo, and it extends from the head to tail. Now I'll be showing you the structure. So this is how it looks, and this is the worm, and it's covered by the hyaline sheath. Okay, this is nothing but the hyaline sheath. And this is the cephalic space. This is the nuclei and the embryo. So that's what we discussed. Now quickly looking at the life cycle, since we discussed the microfilaria, we'll be looking at the life cycle as well. So here in the life cycle, the adult worms are present in lymphatic system of man. Next, the male, it fertilizes the female. Next, what happens is microfilaria are discharged by gravid female. This results in microfilaria in bloodstream. This results in microfilaria being taken by mosquito during blood meal. Next, this results in development in mosquito. After development, there is infective larva and this is by bite of mosquito. The larva reaches the lymphatic channels, and from here it settles in lymph node, then forms adult worms, then moves on into the lymphatic system. Now quickly recapping, the microfilaria is also known as Wucheria bancrofti. The Wucheria bancrofti shows presence of microfilaria. The embryonal stage is nothing but microfilaria. It is colorless and transparent. The blunt head and pointed tail are present. It is mainly 250 into 7 micrometer, covered by the hyaline sheath, and the movement is seen. Somatic cells and granules are present in central axis of embryo and extends from the head to the tail. Now looking at the diagram, there is presence of hyaline sheath, there is cephalic space, there is nuclei present from the top to the bottom, and here, due to the space of the hyaline sheath and within the cell, we can see particular movements, and also the embryo is present. Now looking at the life cycle, the adult worms are present in the lymphatic system of man, and as soon as the male fertilizes the female, the microfilaria are discharged by the gravid female, and due to this, the microfilaria is present in the bloodstream. Microfilaria is bitten by the mosquitoes. It is developed in the mosquito, and there is infective larva, and because of the bite of the mosquito, it is present in the lymph channel. It moves on to the lymph channel and then settles in the lymph node, and it develops into the adult worms, and it is passed on. Now quickly looking at some of the pathogenesis. So here we need to know there's something known as classical filariasis. Under classical filariasis, it leads to lymphangitis, lymphadenitis, lymph edema with hypertrophy. This is nothing but elephantiasis. Now moving on, it also leads to lymphgliovarix, hydrocele, as well as chyluria. So the typical manifestation of filariasis are caused by adult worms blocking the lymph node. So there is blockage of lymph node, and vessels. So it can occur mechanically or due to the allergic infections. So it is mainly by allergy or mechanical block, and what is seen is increased permeability, results in increased permeability, and because of increased permeability, there is increase in protein rich lymph into surrounding tissue. Due to this, it can lead to there is increase in lymph in urine. This is known as chyluria, an important characteristic of the Wucheria bancrofti. Now, the incubation period we have seen is to note is around 1 year incubation period, and the period from entry to stage 3, that is infective stage, appear in the blood. Now another point to note is there is occult filariasis. So this is nothing but it is due to the hypersensitivity reaction to microfilarial antigens. So here the patient they develop massive eosinophilia, this is a point to note, and hepatosplenomegaly, and generalized lymphadenopathy, and pulmonary symptoms. So here what we should know is that the adult one, it produces microfilaria, but it is not seen in blood, in peripheral blood. And are destroyed in tissues and here the features of lymphatic filariasis are absent. So quickly to revise, we have seen the pathogenesis. It is classical filariasis. In this we have lymphangitis, lymphadenitis, lymphedema, and there's hypertrophy leading to elephantiasis, and the lymph phalangovarix, hydrocele, and chyluria are the prominent features. And there's blockage of lymph node and vessels. It can be due to allergy as well as mechanical blockage. There's increase in permeability, which increases the protein-rich lymph into the surrounding tissue. This causes the increase in lymph in urine known as chyluria, and the incubation period here is nothing but 1 year. There's a stage called as occult filariasis. This is due to the hypersensitivity reaction to the microfilarial antigens, and patient is massive eosinophilia. There's hepatosplenomegaly, there's generalized lymphadenopathy, there's pulmonary symptoms as well. The adults are changed to microfilaria and they are not in peripheral blood and are destroyed in tissue. And another point is that the features of lymphadenitis filariasis are completely absent. Now looking at the laboratory diagnosis. The laboratory diagnosis can be, I'm just looking at the headings, that is the laboratory diagnosis. Under this, looking at the direct evidence. This is by just looking into the microscope and checking its structure. So here it's a long procedure, so I won't be going into that detail. There is also the DC test, nothing but diethyl carbamazepine test, as well as indirect evidence. And now there's also the antigen detection. This is by ELISA. There's also DNA probes. There's also PCR. And the treatment is by diethyl carbamazepine. So this is the treatment, and it is given orally at the dose of 6 milligram per kg body weight. And just to go with some details about how do you do direct evidence. So under direct evidence, it appears in large, the microfilaria, it appears in large numbers, and in peripheral blood at night. So it's mainly present at night, and the blood film should be made in the night, mainly recommended in the night, and the thin and thick smears are present. Thin and thick are done, and the thick smear is dehemoglobinized, and both smears are stained with Gemsa. So both are stained with Gemsa. So they are done with Gemsa stain is done. And these smears are then examined under the microscope for demonstration of microfilaria. Then there's nothing but we check under the microscope, and the microfilaria density is low. So if increase in density can be achieved by performing the concentration technique, and this includes the membrane filtration technique, and sedimentation technique. And the microfilaria can be demonstrated in the microscopic mounts of anticoagulated blood, can also be demonstrated in anticoagulated blood by their undulating motion, and displaces the erythrocyte from side to side with their movement. Acridine orange technique can also be used. Microhematocrit tube. So this technique can also be used to demonstrate microfilaria, and also this tube, it includes EDTA, it includes heparin as well as acridine orange. The DNA of the parasite is stained by acridine orange, and then the characteristic is seen. So this affects the DNA. And besides the blood, the microfilaria are also demonstrated in other specimens, such as the other specimens include the chylous urine, includes the exudate of lymphatics, as well as hydrocele fluid. Now there is also some concept of DEC test. It is nothing but diethyl carbamazine provocation test. So here the microfilaria is induced and appear in blood during the day, and by giving diethyl carbamazepine in single dose. Single dose is given. Then what happens is usual peak is reported in case of 15 to 20 minutes of intake. And the detection of worms is by seen in lymph node biopsies, and the worms are calcified and are seen in X-ray examination as well. So next we are looking at indirect evidence. So here eosinophilia is noticed. And it is due to the allergic reaction to antigens. Next, what is seen is serological tests like ELISA, then indirect fluorescent antibody, indirect hemagglutination assay can also be used. Indirect hemagglutination assay, ELISA, and indirect immunofluorescent antibody are done. Then another important thing that I missed is under the antigen detection, there is a special test known as ICT filariasis card test. So here what happens is, under the ICT filariasis card test is a rapid filariasis antigen test. It's a rapid antigen test. So it is immunochromatographic card test, and the test uses monoclonal antibody. So what is used is monoclonal antibody. It is known as AD12, and it's used to detect in patient serum, detect antigen in patient serum, and the test is used in field conditions and can be read by naked eye. So it is seen by eye and without any instrument, and it is also a rapid test, and the blood can be collected during day. So it is also done during day. That is an advantage. Now quickly recapping this entire talk, that is the laboratory diagnosis. You have a direct method. This includes the DEC method, that is diethyl carbamazine test and then the indirect method. This antigen detection is by ELISA, DNA probes as well as PCR, polymerase chain reaction. Treatment is by DEC, that is nothing but diethyl carbamazepine, that is 6 milligram per kg dose. And the direct evidence includes microfilaria, that is large numbers at present at night. Then you have the thick and thin. The thick is nothing but dehemoglobinized, and the thin, so the thick smear is dehemoglobinized, and together thin and thick are stained with GEMSA. And in case of showing the increase in density, the concentration techniques are implemented. That includes membrane filtration technique as well as the sedimentation technique. So the demonstration can also be performed in anticoagulated blood. Then we have the acridine orange and micro hematocrit tube test. So this is nothing but here the components include we can use EDTA, heparin as anticoagulants, as well as acridine orange is present. So this stains the DNA and it is quite visible under this test. So the other specimens you might think that can be used are the chylous urine, the exudate of lymph node as well as the hydrocele fluid. And then the DEC test is nothing but diethyl carbamazepine test. Here it usually peaks in 15 to 20 minutes, and the detection is done by the lymph node biopsies as well as the calcified bodies are shown. And the X-ray examination is seen. The indirect evidence includes eosinophilia, and this is due to the allergic reaction. ELISA, IFA, that is the indirect fluorescent test, and indirect hemogglutination assay is seen. Then antigen detection is seen, and ICT filariasis card test is seen. This is under the antigen detection. ICT refers to the immunochromatographic test. It's a rapid anti-serum test. The monoclonal antibody AD12 is used, and it is used to detect the antigen in patient serum. And here what is seen is it can be seen through the naked eye and does not require any instrument, and it can be performed during the day. So these are the points to be noted. And prophylaxis, I won't be repeating, it's the same, but still I would like to mention. So in case of prophylaxis, what is seen is the vector control should be done. This is mainly done by DDT or malathion. Next, what is to be done is a film of oil must be sprayed over water surfaces. Oil spray should be used, and the larvivorous fish should be added, and the sanitary condition should be increased. So to repeat, the prophylaxis, vector, DDT, malathion can be used. Oil spray is used so that over the water surfaces the vector doesn't spread. Larvaceous fish is used, and sanitary conditions need to be improved. So this was about the filaria. Now moving on to the last topic, we will be discussing a topic on the hydatid cyst, and this is a small topic and I'll try finishing it fast. So here it's about the hydatid cyst. So topic is about hydatid cyst. So this is nothing but the cyst wall is secreted by the embryo. And this cyst wall, it contains the cyst wall, it contains ectocyst as well as endocyst, and the ectocyst is nothing but the outer layer, and the endocyst is nothing but the inner layer, and this is nothing but 1 mm in thickness, and the other one is about 25 micrometer in thickness, and it is tough, acellular, has a laminated hyaline membrane, and it appears as white egg appearance, and of white egg appearance of hard boiled egg. So it's not white egg appearance, it is the white of the hard boiled egg. And when incised, it can be incised or ruptured. So in such a case, what happens is it curls on itself. So it curls on itself and exposes the inner layer containing the broad capsule, scolicals, and then what it does, it exposes the blood capsule, the scolicals, and daughter cyst. Now looking at the endocyst, under the endocyst, it is the inner or germinal layer. And the measurement is already spoken, and it gives rise to ectocyst on the outer surface and brood capsule. And when embryos break free from the membrane and float in the fluid, when it floats in fluid, it is known as hydrated sand, and it also secretes the hydrated fluid. Now, to know some characteristics of hydrated fluid, so let's see. Hydrated fluid, it is clear, colorless or pale yellow fluid. It has a low specific gravity. It's slightly acidic and contains sodium chloride, sodium sulfate, sodium phosphate, and calcium salts of succinic acid. It is antigenic nature, used in Cassoni test. It's highly toxic when observed and gives rise to anaphylaxis reaction. And it also contains hydratic sand in the bottom. Now, another important thing is we need to know that this hydrated cyst is associated with Echinococcus granulosus. So this is important to know. It is associated with Echinococcus granulosus. important. Now just showing the diagram, it looks like this. This is the hydrated cyst. We have a couple of layers. So this is the ectocyst, this is the endocyst, then we have the capsule, broad capsule, this is the scolex. Now quickly recapping, and this is the end. So here we spoke of the hydrated cyst. It's nothing but it has a cyst wall by the embryo. It has ectocyst and endocyst. Ectocyst is about 1 mm in size, whereas endocyst is inner. It about 25 micrometer in size. And the tough, the ectocyst is tough, a cellular laminated hyaline membrane. It is nothing but resembles white of the hard-boiled egg. And when it's inside and ruptures, it curls onto itself and exposes the blood capsule, soluces, and daughter cyst. And now looking at the inner, that is the endocyst, we spoke it is 25 micrometer. It is inner and germinal layer, and it floats in the fluid and it forms the hydrated sand, which later contributes to the hydrated fluid. And the hydrated fluid is nothing but it is clear, colorless, and pale yellow fluid, and it decreases the specific gravity. It is slightly acidic, and present components are sodium chloride, sodium sulfate, sodium phosphate, and then calcium salts of succinic acid are present. It is antigenic in nature, that is customary test, and then it's highly toxic, and then anaphylactic reactions are seen, and hydratic sand is present in the bottom. So we need to know it is associated with the Echinococcus granulosus, and then this stage it has the structure we drew. This is the ectoderm, this is the endoderm, and this is the broad capsule as present, and scolex is also seen. So thank you. This was a long session, and hope you'd like it. Thank you. If you haven't subscribed and want to follow further videos, please do subscribe. Thank you. All the best. Thank you once again.